So I'll be speaking about surgical management of persistent epithelial defects. The layout would be why and when would we start doing surgical management: surface stabilization, surface reconstruction, and surface protection. So these are the three headings under which we'll be doing the surgical management. Well, when is it that you really look at surgical management? Medical and surgical management actually go hand in hand. The goal of treatment is to enhance the effect of medical management and provide further supportive treatment to the medical management. Elimination and correction of confounding structural or functional abnormalities of the ocular surface unit is what forms the basis of doing the surgical management. After acute inflammation settles with medical management, surgical management is usually sought to. Surgical treatment aims at reversing the pathophysiological processes that cause aqueous tear deficiency, conjunctival scarring, keratinization, entropion, trichiasis, limbal stem cell deficiency, and corneal opacification. Of these, the first thing that we really sought usually to when is to conserve the tears in terms of really providing some more nutrition to the ocular surface by doing punctal occlusion. It would conserve naturally produced tears, prolong the retention time of artificial tears, decrease elevated tear osmolarity, and increase the tear volume. They can be done either temporarily by using silicone punctal plugs, or permanent occlusion can be achieved by thermal cautery, electrocauterization, laser ablation, radiosurgery, or direct surgical occlusion. It can either be done in terms of doing a punctal or a canalicular plug, and you can see that after doing a punctal plugging there can be an improvement in the ocular surface because increase in the tears that are there on the surface, in turn improving the ocular surface. So these are the various types of plugs that are available for the punctum and also for the canaliculi, and you can choose based on the requirement, or whenever you see that there is an improvement that is happening with the temporary plugging, you can permanently close the puncta by doing a cauterization. Trichiasis repair is another important thing which is done because ocular surface protection is quite important, and if there is any confounding factor in terms of a trichiatic lash or an entropion, that needs to be surgically corrected in order to have decreased mechanical trauma to the ocular surface unit and the cornea, thus improving the health of the cornea and healing the persistent epithelial defect. That can be done either by epilation, cryoepilation, or electrolysis. Correction of lid malposition is quite important because you need to correct the anatomical defects on the surface and again prevent the mechanical trauma that happens because of the same. Amniotic and mucous membrane transplantation again are important as covered by Pranav about the various effects that the amniotic membrane has in terms of the improved growth factors. They help in improving by providing growth factors that stimulate the epithelial proliferation, suppress the corneal angiogenesis, minimize fibroblast proliferation, and stromal fibrosis. It eventually leads to complete epithelialization, which occurs in 1 to 6 weeks, and within 6 weeks to 3 months, you see a wettable smooth surface. So you can either do in the form of an inlay, overlay, or a sandwich technique. This by itself would be a talk. And limbal stem cell transplantation is sought to whenever there is limbal stem cell deficiency, which restores the corneal epithelial phenotype, restores the corneal epithelial barrier function, and improves the corneal smoothness and clarity. TARSORRPAHY is another very commonly used modality to improve the persistent epithelial defect. This is quite often ignored, and patients who have a persistent epithelial defect, one of the easiest way to help improve the persistent epithelial and healing of the epithelium. So closing the palpebral aperture decreases the area of corneal exposed to the surface and in turn helps in epithelialization. Again, just to summarize, if you're looking at the various grades of the persistent epithelial defect, this is basically in using a prototype of neurotropic keratitis. In mild cases, you can sort to surgical correction with doing punctal occlusion, correction of the lip abnormality, and debridement of the sick epithelium. In moderate cases, you can do a TARSORRPAHY, amniotic membrane transplantation, or conjunctival flaps. In severe cases, whenever there is even thinning of the cornea, you can additionally do a sinoacryl glue, a fibrillin glue, and amniotic membrane transplantation. Thank you very much.
So, a small this one in a small discussion in the panel. So, which is the most commonly used surgical technique?
TARSORRPAHY.
Yeah. So,
it's something that I think any ophthalmologist can do whenever there is a epithelial defect. I mean, a lot of times people don't do it because they feel that it will lead to a lot of cosmesis issues to the patients, but this is something that is quite simple and gives very good results for patients. Again, a good examination, because a lot of times we are just examining the patient on the slit lamp. It is quite important when you're talking to the patient, just look at the face of the patient, whether the patient is an infrequent blinker, whether the blinking is complete or incomplete, or even if the patient who has patient who have increased exposure in terms of thyroid problems. These are also have to be looked at by talking to the patient, and while you're talking, you also do a proper face examination of the patient so you know what you're dealing with. So that would also help you decide your surgical treatment, and look at the whole ocular surface unit as a one single unit, because you may just land up trying to treat the cornea, but if you are having a trichiatic lash or an entropion or an ectropion, these need to be addressed initially before you are trying to treat the persistent epithelial defect, otherwise the defect is not going to heal.
You want to add something?
I won't add. What would be your the point where you'll decide, okay, now medical manager is not going to work, and I'll have to do some surgery?
So usually they go hand in hand. You cannot really say that these are something that would not work and it's only now, because again you have to understand what is the pathology that you are dealing with. See, if it is a limbal stem cell deficiency, whatever medical management you are trying to look at, it is not going to work. You have to understand the pathology behind the persistent epithelial defect, understand the causative effect or causative reason for having the PED, and accordingly tailor make your treatment, because there is no set algorithm that you can follow for these kind of cases. Each case has to be individually handled and based on the pathology treated.
In addition to that, I would also like to add there is a certain time frame that we always keep in mind, that everyone has their own what you call the way they rate progress as far as patient recovery is concerned, but 2 to 3 weeks is a time frame beyond which I think none of us wait before taking a decision to do some sort of a surgical treatment, whether it's a tarsorraphy or an amniotic membrane. I think.
Has anybody had an experience where the tarsorraphy healed the defect, the tarsorraphy was opened, and the patient again came back?
It can happen.
So in that situation,
A lot of times you need to really tell the patients that, I mean, see, it depends on your threshold when would you want to open the tarsorraphy. A lot of times you have to keep it for a very long time. See, because the basic pathophysiology, especially in neurotrophic cases, you're not addressing by doing a tarsorraphy. You're just temporarily healing the defect. But in that case, sometimes you really need to keep it for a very long time.
I noticed this in somebody who's undergone a neurosurgery,
Yes.
especially for the acoustic neuromas, and they'll
That's
end up
what.
having
So in
recurrent
neurotrophic
PEDs.
cases, you really need to.
Mini scleral contact lenses.
Yes. Yeah.
I think they are a good alternative to temporary tarsorraphy.
Again, affordability is a problem. If the patient can afford, it's easy, but sometimes there are cases where even I have done a tarsorraphy and just left it because I know the patient just cannot afford anything else and there's no point in, and just tell the patient, okay, it's going to be a little uncomfortable, but I have kept it just lateral so it won't worsen your vision, but you have to put up with the cosmetic blemish that's there for the greater good. So they're okay with that. They know they can't shell out the money for a Boston scleral lens or a mini scleral. Yeah. Well, but some places they can't afford even that. They're right down to the bone. So can't do that.
Thank you.
Yeah.
Thank you, everyone.
Thank you.
Thank you.